Blog Talk Radio. Welcome to Medicaid Matters, the only live talk show about the business of Medicaid health care. And now, here's the host of Medicaid Matters, Richard Yaden.
Well, thank you, Braley, and welcome everyone to the last show of 2012. It's Tuesday, December 11th, 2012, and you have arrived at the final edition of Medicaid Matters for this year. As you know, normally we do it twice a month, but we're going to take a break during the holidays for our last show. So I'm glad you're here. I'm your host, Richard Yaden, and we're coming to you live from the MMS Group Studios in Brentwood, Tennessee. We're so glad you're joining us today on the only live and interactive talk show about the business of Medicaid health care. Well, it's for me, it's hard to believe that it's only 14 days till Christmas gets here, and 2012 has just flown by. I don't know if it's gone by as fast for you as it has for me, but it has just soared by. It seems like just yesterday we were wondering if the Affordable Care Act was ever going to survive, and here we are, poised for 2013, and perhaps the greatest movement, the greatest shakeup in Medicaid that has ever occurred, certainly since it first came around in 1964. This has got to be one of the biggest movements that we have coming for us in 2013. There's just no way to underscore how monumental the task is and how monumental it is of the job that we've got in front of us. So what has been, though, when you look back on 2012, what has been some of the most significant developments in Medicaid? What have been the most significant issues? What's going to happen in 2013? What's on the drawing board for our next moves? Well, we're going to try to answer those and some other questions over the next hour. I'm going to be joined by several guests on today's show, people from across the Medicaid spectrum. Some of them have been guests on the show before, but we're going to be joined. They're going to be sharing their thoughts on these questions and others as well. Also, last year around this time, our show announced that we're going to be giving out a year-end bonus. And we gave that out to some of our listeners and some of our viewers. That promotion was actually so popular that we've decided to do it again this year. So we're going to be giving 3 of our listeners or viewers a year-end bonus before the end of next month. And I'm going to give you some more details about that later in today's show. So be sure you stick around and get to the scoop on all of that. Well, I'm sure you have an opinion about what has happened in Medicaid over the last year, and I'm sure you have some thoughts about what will happen in 2013. I'd like to hear from you. I'd like to hear what you have to say on this subject as we go through today's show. You can give me a call, and we'll talk about it. Just call me at 626-657-2125. That's 626-657-2125. We can have you right here on the air. Hey, you don't have to worry about giving out your name, your full name, or your company if you don't want to. What we're interested here is your individual perspective. You as a professional who's working in the business of Medicaid health care, whether you're on the vendor side of things, you're with state government, you're with a health plan, or with a provider, it's your opinion and your perspective that we're really interested in and we'd like to get. Now, you can't, if for some reason you can't make that call, or you're in a place where you can't make a call and have that conversation, then you can also send a comment into through Twitter if that's easier for you. Our Twitter handle is @Medicaid Talk, and we do monitor that throughout the show. And if you want to send us a comment or a question, you can do it through there, and we'll get it on here as soon as we can. Well, not only has a lot happened in Medicaid, in the business of Medicaid healthcare, but a whole lot has happened here on Medicaid Matters in the last year. 2012 was a very, very big year for this show. We saw tremendous growth in our audience, our show reaching over 70,000 people. And this past year, we broadcast 3 shows from live events. Some of got a chance to meet some of you at some of those conferences, and it was good to have a chance to meet you personally. We produced over 23 shows during the year, and we hosted 49 live guests, which included representatives from CMS, from state Medicaid plans, from health plans, from the vendor community, and from the comments, from the inquiries, the calls that I have received. I think 2013 is going to be an equally big year for this show, and a very big year for Medicaid Matters. So we hope you're going to be a part of it as well, and that you're going to be continuing to join us. And before we get too deep into the show, I think it's appropriate, particularly this time of the year, I want to just take a minute here and give thanks to and thanks to all of our guests over the past year who have taken time to be on their show. They have very generously shared their expertise, very generously shared their comments and their thoughts with us and with you. And I know from what I hear from our audience, you get a lot out of those thoughts and those comments. So I want to thank them for doing that. I want to thank our sponsors who continue to support this show and to be a big part of what we do. And I certainly want to thank my team at Managed Medicaid Services who do so much behind the scenes to make this show happen. It's not as it's not as easy as hopefully it looks like it is when you're watching the show, but a lot of work goes in between shows to get these off. So I want to thank my team. And then, of course, I want to thank each of you, those of you who are listening or watching the show. Your support, your continued participation in the show is really what makes this special. It's what makes Medicaid Matters unique. The fact that your group, our audience, continues to grow every week just affirms to me that we're on the right track here. We're bringing you the information that you want to have, and that's exactly why we started this show a year and a half ago. I think we grew a lot through 2012 in bringing the right kind of content to you, and that's what we want to do. We want to make this live, interactive. We want to bring the most relevant information. I'm always interested in your comments. I'm always interested in your suggestions about the show. You can leave them right there on our site, MedicaidTalk.com. If you're not there and you want to watch the show, I really encourage you to do that. You can go there and watch Medicaid Talk, Medicaid Matters right there on MedicaidTalk.com. Well, as I said, 2012, we had a lot that went on in 2012. Some of the things that really stick out to me, one is an element of anxiety that seemed to really persist throughout the Medicaid business community throughout 2012. There was anxiety over the Supreme Court decision. Seems like that was just years ago, but it was really just about a little less than 6 months ago when the Supreme Court ruling on affordable care came down. But I was in Washington around June meeting with some people and clients when all of that was about to break, and there was just a tremendous amount of anxiety that was part of that whole process of waiting to see what was going to happen. Of course, it really didn't stop the anxiety when the Supreme Court launched announced their decision. It kind of left it very ambiguous for states to some respect about which way they wanted to go with Medicaid and expansion. And even to this day, we're still starting to get some clarity around which way and which direction that states want to go. There was also an element of, I think, surprise at the Supreme Court decision, an element of surprise in the sense that we were expecting it kind of to be an all or nothing. And maybe that has been the biggest decision that we have had in or maybe the biggest event that happened in 2012, because there was so much momentum building up to Medicaid expansion, and then the hearing started. I guess that was in March, and then we had this long period of waiting when all types of signals were coming out that there was going to be big changes to the Affordable Care Act, that it may not survive. In fact, I think we actually did a show on what we could probably expect based on all the pundits and everything that was being talked about. And when the decision came out, it was pretty surprising, I think, for a lot of people. So just a couple of my observations. I'll share a few more of those with you as we go through. But I want to bring on the show someone who you've heard from before, if you've been a regular listener of this show. Someone who has who I think is a real friend of the show, and he's a former state legislator, a former mayor, a former adjunct faculty in public policy at Trinity College and Wesleyan University. He's has been the executive director of 3 nonprofits. He's now a writer and consultant on mental health and public policy, and that's Paul Gianfrido. Paul, welcome to the show.
Hi, Richard. Thanks for having me on again.
Well, it's always a real treat to have you on here. I get to read a lot of what you write, and for those of you who don't subscribe to Paul's blog, Paul, give them the URL of your blog so they can go to that.
Sure. It's Our Health Policy Matters, and it's at just pgianfrido.blogspot.com.
Okay, and we'll post that on our show pages too, Paul, so people can get to that. But I read that every post that you put out. It's always lively, always insightful. When you think about 2012, Paul, what kind of stands out in your mind with respect to Medicaid?
I think the Medicaid expansion is just key. And while the Supreme Court decision itself certainly framed this issue for the last 6 months of the year, I think so much of what has happened since then, with the reaction of the states and then yesterday's decision by the federal government not to allow states to do partial expansion, I think as this issue has unfolded over the last 6 months, it's continued to be an extraordinarily interesting time for the Medicaid programs.
Well, there's no question. It has. I don't think I've seen this much activity with respect to Medicaid and the Medicaid programs since its inception. And you've been in a lot longer than I have, too.
Yeah, and I would agree with that. I mean, Medicaid used to be an issue talked about primarily by state legislators when budget problems were occurring, but now it's in everybody's vocabulary. And I think for the first time, really in the last year or so, most of the general public is finally able to distinguish, at least to an extent, Medicaid from Medicare. And I think a lot of the public has never even focused on the fact that those are two vastly different programs that just happen to have been enacted at the same time.
Yeah, I think last year a lot of people would have gotten Medicaid and Medicare confused, people that aren't in the industry, and I think now a lot more people are clearer on what the two are about.
I agree with that.
Now, since I have you here on the phone, and the ruling that you had just mentioned earlier is so new, could you take just maybe 1 or 2 minutes and kind of explain for folks just what the federal government was saying about the ruling on partial expansion?
Yeah, right after the Supreme Court decision, which, as you were mentioning just a little while ago, caught most everybody by surprise around the Medicaid expansion, both the Congressional Budget Office and the Department of Health and Human Services suggested that there were now 3 options available to the states based on the Supreme Court decision. And one option was they could expand Medicaid all the way. The second option was that they could reject the expansion and just keep their existing Medicaid program. The third option, which took people even more by surprise, was their suggestion that they might be agreeable to a partial expansion. In other words, taking Medicaid not up to 138% of poverty for everybody, but maybe taking it up that high for just some populations, or taking it up only part of the way there for everybody. And for the last several months, a number of states who have otherwise said they were not going to expand the Medicaid program have suggested or hinted that they might look more favorably if they were allowed to do a partial expansion. As of yesterday, though, the Department of Health and Human Services finally came down on the other side of the issue and said, which is something that a number of advocates, I might suggest, wanted them to say, that no partial expansion would be allowed. This has to be an all or nothing for the states. So those dozen or so states that have been seriously looking at a partial expansion option are now going to have to go back and either go all the way up or all the way down with it.
Well, thanks for kind of going through that. I know it's a complex issue, but I think you really summed it up great in that short period of time. We have someone from Twitter who has asked a question. How has this year affected behavioral health in Medicaid? And I know that's an area of your interest, Paul. What could you tell us about that?
Well, I think that the behavioral health impact, could be serious if the Medicaid expansion doesn't go through in a given state. Just for a little bit of background for people who may not be aware, over the last 4 years, the states have cut their cumulative Medicaid or cumulative budgets for mental health by a total of $4.6 billion over the last 4 years. And this is further harming an already constrained system that doesn't have enough resources to serve all of the people that need service, which is why so many people with serious mental illnesses are ending up in our jails and prisons. But the Medicaid expansion, because it was largely an expansion that was going to benefit people who were single adults with chronic conditions, is likely in most states to disproportionately advantage people with chronic mental illnesses. And while there's a lot of data that would explain why, probably the simplest thing is just to point out that people with a serious mental illness on average make about half what people make who don't have serious mental illnesses. And that number is somewhere in the $20,000 to $30,000 range on an annual basis, which puts them squarely in the group of people who would be eligible under Medicaid expansion. So if Medicaid expansion goes through, it's going to be a real benefit to people on the behavioral health side. If it doesn't go through, on top of all of the state cuts that have been coming down in the last 4 years and look like they're going to be continuing over the next year or two, it's going to be a real disaster. Yeah,
no question about it. Well, Paul, I know we promised that we'd only keep you for a little while. I really appreciate you taking the time to call in. We're going to have to take a break here and go to one of our sponsors. But when we come back, we have Dr. Greg Payne that's going to talk to us a little bit about his perspective. So, Paul, again, thanks for being with us today.
Thank you. Happy to do it.
All right. We'll be back in just a moment, so stay with us. When we do come back, we're going to have Dr. Greg Payne's going to join us, and he's going to talk about his observations from 2012. Dr. Payne is medical director for the National Medical Policy and Operations at Aetna, and also the past Medicaid director for the Commonwealth of Virginia. So hang on, we'll be right back.
Nurses who want to stay on top of their skills know that the Nursing Informatics Learning Center is the place to go. You'll find articles, tutorials, a blog, e-zine, board-approved CE credits, links, assessments, and consultant services, all available to the global nursing community in one place. If you're a nurse or if your organization employs nurses, you need to visit the Nursing Informatics Learning Center.
By providing access to the care they need and the quality they deserve, Medicaid health plans enhance health outcomes of our nation's underserved. Listen to this letter to a Medicaid health plan that helped save the life of Juan, a 4-year-old with a rare heart disease.
All of your efforts have created a miracle for my son. Even though he was so close to death, you helped. You made a difference. Now he's coming along, little by little, step by step.
Medicaid Health Plans of America, ensuring access to better health care. Learn more at mhpa.org.
Elevating the quality of care with less cost. Today, that's the job of every Medicaid managed care company, but it can't be business as usual. Companies have to coordinate care a different way. The solution is managed Medicaid services. Through our virtual case manager network, our teams of Medicaid assessment specialists, and our new advanced care transitions program, companies can dramatically raise the quality of care without increasing their cost. Visit us today at MedicaidServices.net. Managed Medicaid Services, your best source for innovative care management.
And welcome back to Medicaid Matters. This is the only live and interactive talk show about the business of Medicaid health care. Well, I mentioned at the beginning of the show that we were going to be giving away a year-end bonus. And we want you to join Medicaid Talk, join the community, and enter to win this bonus. All you have to do is provide your email address. You can do that in the upper right-hand section of the MedicaidTalk.com page, and you'll be entered to win a $100 gift card from Medicaid Talk, and a dozen others will win Starbucks gift cards as well. The winners are going to be announced on our January 8th show, so sign up today and be a part of the Medicaid community and get that year-end bonus. Well, I am now being joined on the show by Dr. Greg Payne. Dr. Payne has been a past guest on the show and has a very unique perspective, having been a Medicaid state director as well as now a medical director with one of the larger health plans in the country. Dr. Payne, thanks for joining us today.
Richard, great to be here.
Well, you've had a few changes going on since you last talked with us.
Well, Richard, as usual, your show is at a pivotal time in healthcare. I think a lot's been in the news recently about Medicaid. I think this news about no flexibility will be allowed in terms of expansion is a really important one. So, and we'll have to see in 2013 which way it goes, which states will participate, and then. I think some of the other big issues are these exchanges, which way that's going to go. I saw the governor of Tennessee on today speaking about they're not going to do their own at the state level.
Yeah.
So just a lot going on in Medicaid, and I think that'll lay the groundwork for the action in 2013 as well, how this all plays out.
Yeah, that was certainly big news here. I think because we're here in the Nashville area. I think up until that announcement a day or so ago, most people thought we're going to go the other direction. So it was a little bit of a surprise, I guess, but maybe not entirely unexpected. And I think it's just going to be very interesting between now and in the next several weeks as we see which way these different states go. When you think, Dr. Payne, back on 2012, what would you say do you think is perhaps one of the biggest developments in Medicaid over the course of the last year?
I think the election has cleared up that health reform is here one way or another. So I think the debate now is in terms of the implementation and how. So I think the election results at least clarified that this will be around. I think the other big factor that occurred in 2012 and will continue is just the tough economic times that are out there and the pressure that states are under with their budgets. That's not going to go away, and I think that's one of the key drivers behind some of the discussion now about the exchanges and the participation rate and so forth. So those two big points I think will continue on as it work with the federal government to try to decide what they're going to do to implement.
Yeah, no question. When you think back on your time as state Medicaid director for the Commonwealth of Virginia, what were some of the things that you were doing when you were there? And it's just been for the benefit of our audience just about a year ago. What were some of the things that you were doing then that you see now starting to come to fruition within the states through 2012?
Yeah, I've been blessed and fortunate to have the chance to be the Medicaid director for Governor McDonnell in Virginia for a time, and I've also was health director in District of Columbia, which had oversight for Medicaid prior to that for Mayor Williams. So I was real fortunate to have that opportunity in both places. both of which are very different, as you can imagine, in philosophy, but a lot of similar, I think, underlying principles. I think one of the unifying things is I think all states, everybody's trying to find better ways to deliver care, lower cost, better outcomes. I think a lot of progress has been made. ACOs, electronic health records, the movement toward outcomes and paying for good results. But still, that's a big concern still for states is can we really lower the overall cost of Medicaid and get better value? That's still an open question, and it's certainly on people's minds. I think a second unifying factor I've seen in Medicaid is just states, cities, the budgetary concerns are paramount right now. Less revenues coming in. The staffs in Medicaid are great people, but they're working really hard and they're stressed and so it's hard to execute some of these things going on. We've never had more going on since the creation, I guess, of these two programs back in the 60s. So it's just a dynamic time for Medicaid of potential expansion and a lot of new innovations, but it's also a time of bad economics and a lot of stress at the state level to implement things. And so I think some state legislatures are having questions, do we have the 10%? I mean, even if the federal government pays most of it, do we have the money? Can the federal government continue to provide the 90% in these times? And can we continue to innovate with ACOs and other means to improve the value in Medicaid? Big questions, and I think some of those things are in common wherever you go.
Yeah, no question. Looks like everybody's active on Twitter today because we've got another question that just came in that they'd like to ask you, and the question is, what states, Dr. Payne, do you think are doing the best job right now, certainly given the difficult economic situation that all states have been working through?
Yeah, I think I'd like to, I'm going to be diplomatic. I think all the states, wherever they're coming from, different philosophies, their governors, legislators. But from where I sit and what I've seen, I'm sure many of your listeners would agree. We have a lot of good people around the country working this in different ways. And I think the unifying principle is we're all trying to do the right thing. That said, I think in some states where they're a little more progressive or willing to try things, have done some good jobs with innovation pilots and are further those development, although it's catching on everywhere. I think, as I've said before in the show, I think the big challenge, the real important thing here is how we can improve the care coordination and value in the complex population in Medicaid, those with disabilities, some of the elderly, mental health, and the like. I think that's the real challenge. Can we get better coordinated care principles, better use of electronic record and health outcomes, and better coordination with the acute side to really get a better value and hold the line on future costs, but still deliver the benefit to some of our most vulnerable citizens? That, to me, is really the big question. That's what 75% of Medicaid costs. And under any scenario, health reform or not, exchanges, ACOs, whatever, that's a central question that I think a lot of smart, good people are working on all over this country. And some are blazing the trail for the rest of us, and we'll see how that plays out in 2013.
Well, when you get right down to it, delivering that high level of quality care is what we're all trying to get to. I mean, that's the name of the game. And I think a lot of times we get caught up in these issues about funding and regulations and so on. All that's important. I'm not trying to minimize that, but at the end of the day, it's how do we help these people get better and stay better. And we can't lose sight of that. That's for sure. Last thing I wanted to ask you about, as you have your health plan hat on, and you're looking out into 2013. Tell me what you think is going to happen. What are some of the kind of the big pieces that are going to happen with Medicaid in 2013?
I've had fortunate experience to wear a lot of hats. As an ER doc on the provider side for many years, seeing Medicaid patients, and been a public health director, a Medicaid director, and then work with health plans, and I'm sort of involved with working in health plans now. And what I see going forward, Richard, is I think the health plans and the state level is really where most of the action is. The federal government, look the way CMS has set this up, they're really relying on states and health plans, of course, who contract and work with states to be the innovation labs to execute on some of this complicated stuff that's being put forth in the proposed rules. So a lot of burdens going down to the state level and health plan level and on to the provider community to try to innovate and do care better. And that's that's it's a challenge and an opportunity. And I think healthcare is rising to it. It's a tough climb in these times, but I've seen definite progress over my career as a young ER doc, starting out in the 80s till now. You can really see the steep slope of increase that we're getting better coordination. We're using electronic records a lot more, and I think getting much better coordination, outcomes focused on these programs, and are getting better value. But that said, a lot of money. There's issues about fraud and coordination, and the dollars will say, we've got to get better outcomes before we should expand and do more. So, we'll just have to keep working at it. And I do want to say in closing, Richard, I think your show has done a lot to raise the profile of Medicaid and get people to collaborate and raise issues, and so we appreciate that, and other things that really increase the awareness of Medicaid. And I think that things are going to get better and continue to get better. So with that, thank you so much.
Well, and I appreciate you saying so. We are always glad to have you on the show to talk with us, Dr. Payne. I appreciate your comments, and we hopefully in the next year or so we can have you come back on and talk a little bit more about what's going on.
Okay, thank you.
All right, have a great day. Dr. Greg Payne with Aetna. Glad to have him on the show. Hey, I wanted to ask you if you haven't registered yet for the Medicaid Innovations Conference. You need to do so. It's February 5th through 7th at the Gaylord Palms Resort and Spa in Orlando. Yes, I said Florida in February. I'm going to be the chair of the conference, but really there's much more going on there. This conference is designed to be the meeting place for all participants in the Medicaid universe who want to participate, who want to share, who want to learn about innovations that promote performance improvement, that promote Medicaid transformation. You can get a $200 discount off the cost to attend. Just go to MedicaidTalk.com and we'll have it there for you. The discount code is right there, and then you can just click on the Medicaid Innovations icon, and that'll get you registered. I'd really like to meet you personally. We've done this at several events. It's always great to get to meet our listeners and our viewers, and I hope to see you there. We'll be right back in just a few minutes.
Medicaid Matters is now booking guests. Who are we looking for? We're looking for people who can bring a fresh and unique perspective to the business of Medicaid health care. Do you have an idea that is unique, innovative, maybe even controversial? We want to hear from you. Go to MedicaidTalk.com, complete our guest questionnaire, and we'll be in touch with you to schedule an upcoming episode. Be a part of Medicaid Talk.
The Medicaid landscape is changing fast, and that means challenges, but it also means opportunity. Opportunity for you. And that's why you need to visit MedicaidJobs.net. MedicaidJobs.net is the place to showcase your talent to Medicaid companies, search for jobs, research the latest career trends, and register for the free Career Optimizer service. Don't wait. Go to MedicaidJobs.net today.
You're listening to Medicaid Matters on the blogtalkradio.com network.
Well, and just a little later in the show, we're going to hear from Matt Salo, who is the Executive Director for the National Association of Medicaid Directors. You're going to want to stick around for that. But we want to dig in here and talk more about some of the things that have happened in Medicaid in 2012 and some of the events that we might be looking at in 2013. You know, when you look back on 2012 and some of the significant Medicaid topics, there's no question that health information technology is certainly in the top 5 on that list. I thought it was rather fun when we were at the Medicaid Enterprise Systems Conference back in August. The talk was really about how the private sector was going to have to really take the initiative and move this piece forward in Medicaid. And earlier in the year, in fact, at that conference, Elizabeth Reed was on our show and talked about this issue Elizabeth is now a member of CSG Government Solutions Healthcare, and she is a member of the Government Solutions Healthcare and Human Services Practice. Excuse me. Prior to that, though, she was with CMS, and she is a nationally recognized expert in Medicaid management information systems and other federal and state healthcare system operations. Last week I had a chance to talk with her about her observations in 2012, and here's what she had to say.
Elizabeth, when you think about the different projects that you've been involved with, I know that you have a very wide perspective on what's going on in Medicaid this year, but when you look back at 2012, what would you say are one or two of the things that you think were the most significant developments with respect to Medicaid in the past year?
Well, I feel that 2012 was a very busy year for Medicaid. The Affordable Care Act outlined many new provisions that states had to adhere to. I think last year was spent, a lot of time was spent preparing for the eligibility and expansion project. There were some key events or factors that implemented their decisions, which were the Supreme Court ruling back in June, the election, and the regulations that were published by the feds. And so a lot of time was spent on whether making a decision on whether they should build a state exchange or utilize the federal facilitated exchange. There were other state focus spent on operating rules, which is part of the ACA. The first one regarding eligibility and claim status is to be implemented on January 1st of 2013. Provider enrollment was a big issue, and of course the updates to the NCCI. And I think that the largest implementation for 2012 was the 5010 transaction, which is, as you know, a prerequisite for the ICD-10 implementation. And, you know, I think with the announcement of the discretionary period from CMS on the enforcement, I think that allowed for a smoother transition for 5010.
You know, you spend a lot of time at CMS, and I know your expertise is MMIS. What do you think was the biggest development at CMS in 2012 with respect to health IT?
There's a lot of concern about data analytics, and so, you know, with the development of new data reporting and the new MSIS file that's coming out, I know they had a pilot program, a 10-state pilot program that, you know, which I believe the expanded data elements was, you know, over 500. And so, you know, there's a lot of interest in, you know, viewing data, you know, doing research on quality measures, and, you know, improving healthcare. And again, with the expansion of the healthcare eligibility, you know, there's going to be more people eligible for the Medicaid program, you know, which is going to translate into more data. So I think in the future, you know, it's going to, you know, with all the updates and you know, with the healthcare IT infrastructure focused, you know, on service-oriented architectures and cloud computing, and just a constant improvement in that infrastructure will help obtain this information. And then also in 2013, you know, the Stage 2 meaningful use for electronic health records, you know, will be coming out actually in 2014, but, you know, a lot of people are going to be spent time preparing for obtaining, you know, information and for that initiative as well.
I had several people tell me that they felt like CMS was more open to outside innovation and influence on their IT standards in 2012. Is that something that you've seen as well?
I do. You know, I mean, there's a lot of new technology that is continuously, you know, evolving, you know, all the time, and they're always receptive, you know, to better ways of doing things. So, they have an innovative program there, where they also provide grants, for coming up with these new solutions. So yes, there's always interest in that.
What do you think are going to be the biggest hurdles that we're going to have to overcome in Medicaid?
Politics.
Yeah, unfortunately, that's a big part of it, isn't it?
I think that's always the biggest hurdle is the politic piece of it. There's a lot of great people out there working in the industry that are, again, continuously contributing to improvements. As far as, the IT infrastructure and the Medicaid program, so I think 2013 is going to be spent, a lot of time is going to be spent preparing. I think 2014 is going to actually be the bigger year when things actually get implemented. Mm-hmm. So 2013 is going to be more, in the preparing phase. Yeah,
pretty much so. Well, Elizabeth, thank you for taking a few minutes to talk to us about this. I think you bring a unique perspective, having your time in CMS and now combining it with being in the private sector. It's a unique perspective that I know our listeners and our viewers like to hear about. So appreciate you taking some time and talking to us today.
Well, it's good to hear from these different perspectives. I think a lot of thought about what has been going on in Medicaid in 2013, and I think an interesting perspective about Medicaid in 2012 and what we can expect in 2013 comes from the leadership of some of the Medicaid health plans. Their operational and strategic insights are certainly well in tune with the realities of managing care for Medicaid members. I had a chance recently to speak with Robert Mendonza about this. Robert is the past president and CEO of Aetna Better Health in Illinois. We talked about what he saw as the most significant developments during this past year, and what's driving those developments, and what it might look like, and what we might have to look forward to in 2013. Let's listen to what Robert's comments were.
When you think about 2012, and here we are at the end of the year, and it has been quite a year for Medicaid. A lot of things going on. But if you were to have to put your finger on it, what would you say in your view, one or two of the most significant developments for Medicaid in 2012?
Yeah, that's a great question. And I'd say my experience obviously is specific to Illinois, but I think it's true in other states. But I think probably the biggest development was that Medicaid essentially could have bankrupted the state. And so that led to a lot of things that people thought would never happen. And probably the most significant is that there was much more of an embrace towards moving Medicaid into managed care. I think that from the legislative standpoint, from the key advocacy groups, one thing I saw consistently was a desire that, if I have to either cut the Medicaid benefits or move to managed care and preserve the benefits, I think that there is the feeling was I'd rather move to managed care because I think that could be more effective, but preserve the coverage for the people that need it the most. So I think that was a very, very significant change that we saw year over year, and I don't see that changing given the size of the Medicaid deficits and the size of the Medicaid budget. It's the largest budget item for the state, and so it's going to continue to get that kind of pressure. The other piece that I'd say is that it's happening slowly, but I think that the provider community, which has been very hesitant to join the program, is starting to also understand those dynamics and trying to figure out, how can we potentially start to work together to make it work. Now, again, it's in its infancy stages, but I did see some positive signs of at least wanting to start to work together to find ways to really treat these people, neediest of the people. How do we really reduce readmission rates? How do we keep these people out of the ER and improve the quality of their lives? So I think, and that's just going to grow, as we go into next year.
In 2012, what do you think were some of the things that were driving the momentum to that? I know funding and budget was one part of it, but there was more going on than that, wouldn't you think?
I think that when you break down the Medicaid numbers, and in particular, if you look at what are the cost drivers, and so if you look at entire Medicaid population, you have the moms and babies, the TANF, and then you've got largely the age blind and disabled, and the age blind and disabled roughly account for under 20% of the total population. Yet they account for well over almost 60% of the cost. And so I think as people then, again, driven by the focus on the cost drivers, start to realize, well, what do we need to do? And then you start to understand that these people, these age blind disabled, are the mentally ill, are those that basically we don't have mental health systems. So how do we start to build these things? So how do we really start to coordinate care for these individuals and start to engage them? So I think that was another important, I think, as people start to understand or really know that Medicaid could bankrupt the state and find solutions, then start drilling into, well, what are the exact kind of programs and what are the populations that we need to be focused on. Mm-hmm.
When you look at 2013 and Medicaid expansion, all the issues that are involved, what do you think we're going to see happen with Medicaid in 2013?
Well, I think with the Affordable Care Act confirmed, because I think a lot of especially the hospitals, were kind of sitting on the sidelines, as opposed to moving, and not some, but I would say many were kind of sitting on the sidelines. And I think now that that's confirmed and they know that Medicaid expansion is coming, I think that they're going to need to start working with the managed care organizations, with the state and other organizations to truly start to create a system of care for these. These are the neediest, the most complicated consumers, patients that I have ever managed. And so, and it doesn't take, an MCO is not going to do it alone, and a hospital is not going to do it alone. What it's really going to take is the system working together with the physicians, with the mental health community. How do we share data? How do we share information? So what I hope for, start to see as people embrace or understand that Medicaid expansion is coming, that we start to figure out how do we actually create a system that is going to be able to treat and improve the quality of lives of these individuals that are costing the state and the taxpayers a great deal of money. And it doesn't need to happen, and because it's costing a great deal of money, and it's also incredibly poor quality. And I think we can really improve the quality and dramatically improve the cost, but it's going to take us working together.
Collaboration is going to have to be a big area of focus for everybody involved in 2013, I think.
I completely agree. I think the dynamics of, the negotiation being all around what's the price I'm going to pay you needs to start to change to how do we start to understand that we can, if we improve the quality, then we can improve reimbursement as opposed to just being on a fee-for-service basis. And I think those are the conversations and discussions that really need to take place and really move it up from the kind of the managed care contractors up into the C-suite.
Elizabeth and Robert's comments are interesting, since we've heard from many in the healthcare industry that the healthcare industry can start to be more like an industry. I remember almost a year ago we heard from Dan Rizzo. We heard from Dan Rizzo almost a year ago that predictive analytics like what Visa and MasterCard use can be applied to healthcare. So Robert and Elizabeth's comments are very much in sync with the fact, what we're hearing from many in healthcare, that the healthcare industry has to become more like an industry. And in fact, one of the key sessions in February at the Medicaid Innovations Conference will be led by Cheryl Slagle from CareSource on how we can use data to mimic the major companies and to do a lot of the things that they're doing. So if you're planning to be there, I know that's going to be a session that you're going to want to be a part of and be there. Maybe more than before, when you think about Medicaid in 2012, maybe more than ever before, Medicaid is in the news a lot, and I think it's going to be in the news a lot going forward. Now this isn't very scientific, but I was just curious. I Googled the search term Medicaid news articles 2012. I Googled that search term just to see, what would show up. Well, what I got was 18.4 million pages. You compare that to the same search for 2011, it was 5.4 million pages, a threefold increase in 2012 of news items and pages referencing, talking directly about Medicaid. And I had a chance to talk with Clay Ferris, who's the managing editor, and he offers this, managing editor of mostly.medicaid.com, I should say, and he offers this about Medicaid in 2012 and 2013.
For what I think has been the most significant development for Medicaid in 2012, I think given the extensive coverage of the election and Medicaid in the context of the election, I think the biggest thing is that Medicaid made it to the kitchen table. Medicaid made it to out of the advocate discussion, out of just something being discussed on the left when there's an election year. And now, when you combine that with what's happened in the economy for the last several years, I think it's a much more acceptable idea to be providing a minimum level of care than it has been up until now. So I think the awareness of the entitlement grew. There were a lot of people that would confuse Medicaid and Medicare, and I think a lot of people still do, but not as much after 2012. In addition to awareness of the entitlement itself, I think an acceptance of the entitlement, of where it's all a matter of where we draw the line. We will always say, yes, everyone should have basic needs such as running water or electricity, and it's less debatable, I think, after 2012 with all the coverage and discussion that happened, that health care is also one of those minimum needs. Where it's going in 2013, I think, is an interesting juxtaposition to that, because we at Mostly Medicaid still think that the fundamentals are off. We think that the financing is not set up right. We think that ACA does a lot of really good things. Health reform does a lot of really good things, but the thing it doesn't do is fix what's broken with Medicaid. And it's going to, where all those extra folks that are going to get covered, it's going to be very natural for a lot of that to go to Medicaid. So we think
So, and Clay had a little bit more there to say, but I wanted to mention that we've got a segment here at the end that I want to make sure we get to, and I want you to hear this presentation that comes from the E-Advocacy Summit. The summit's organized by the Global Healthy Living Foundation and Eli Lilly and Company in partnership to provide advocacy organizations with the healthcare social media tools to educate their stakeholders. Now, this is a short clip from a presentation given by Matt Salo, who is the Executive Director of the National Association of Medicaid Directors. It's been written, and I quote, "There may be nobody more imbued in the policy of Medicaid than Matt Salo." And in this talk, Matt gives perhaps one of the best explanations about how we have arrived at where we are in Medicaid today and where it needs to go. And we're gonna move on with this quote, and let's listen to what Matt has to say.
And in fact, since the recession hit, state revenues and state economies hit essentially the worst period since the Great Depression. And while they have rebounded, state economies are getting better, jobs are coming back, state revenues have yet to return to the pre-recession levels. So we're closing in on 2013. We have yet to get back to where we were in 2008. And why is that important? That's important because, on one hand, Medicaid is an interesting program in that it is what we call counter-cyclical. And what that means is that at the time when states are least able to afford contributions to Medicaid during a recession, that's the exact time that the need for the program is the greatest. Recessions happen, people lose work, people become uninsured, people end up on Medicaid exactly at the time when states don't have the money to pay for it. And you could say, well, why don't you just do what the federal government does and pass the problem on to somebody else or somebody's grandkids? And the challenge is that at the state level, every state has a balanced budget requirement, which means that every year or a biennium in some states. You got to reconcile revenues in and spending out. And when revenues go through the floor, that leaves states with very, very difficult decisions. Because at the end of the day, for a year or two, you can kind of move money around and you can rebalance things and draw on rainy day funds. But in an extended recession like the one we've had, it forces very difficult decisions. And at the end of the day, you're really left with two major options when you're talking about budget shortfalls of the nature we're talking about. Those two options are significantly raising taxes or significantly cutting spending. And again, if you live in a state, and I imagine most, if not all of you do, you know that the political appetite for raising taxes isn't there. So that's left states with cutting spending. And Medicaid is 20% or so of the average state budget. So it's a pretty appealing target. So states have been finding themselves in this very tough position of, at a time when the country needs Medicaid the most, when people are uninsured, when people need to rely on Medicaid, states have been struggling with how to keep the program afloat and with the desire and the sort of the struggle to try to reduce spending. Now, part of the challenge is that that's not going to work either. You can't, we've discovered that we really just can't cut our way out of this problem. Medicaid is, I'll oversimplify this, but Medicaid as a budgetary item, as a program, is a function of a simple math. We pay providers to deliver services to people. And that's essentially what we spend $420 billion a year on. And so the desire to reduce spending generally comes with, a need to hit somewhere along that equation. If you covered fewer people, you could spend less money and maybe balance your budget. If you covered fewer services, you could spend less money, balance your budget. Or if you paid providers less, spend less money, balance the budget. And that all works in theory. That no longer works in reality for a variety of reasons. Like I said, we cover 62 million people right now. Current federal law prohibits states from reducing eligibility. You can argue that's a good thing. Don't want to increase the number of uninsured in a recession. I get that. But one option that's off the table, paying providers. Medicaid doesn't pay providers well to begin with. And if you're a provider group or you know this. Look at primary care. For primary care physicians, Medicaid on average pays about 70% of what Medicare pays. Medicare only pays about 70% of what the private market pays. It's a pretty low threshold upon which to get a whole lot of savings. And then services. What does Medicaid provide that it doesn't need to, or that people could live without? Prescription drugs, technically optional, could get rid of it. Not going to happen, not a good idea. Long-term care, nursing home coverage, a lot of that's optional. Stop covering that, not a good idea. So it really leaves states in kind of a quandary. What do you do here? There's no way to cut our way out of this problem. So what we're seeing is, and I'm going to kind of make the nerd reference to Star Trek. If you ever watched the original show, or I think even in the remake, at one point Captain Kirk is sort of given this test. They call it the Kobayashi Maru, and it's intended as a no-win situation. It's a simulation intended to see how people deal with clear defeat. He cheats the system. He wins. He fixes it. And in essence, we're kind of at that point with Medicaid, because we can't cut our way out of this problem, and we can't raise taxes to get out of this problem. So states are looking to rethink the questions. And the question they're rethinking is, wait a minute, what exactly is the problem here? Is it that we're covering people who shouldn't be covered? Is it that we're covering services that don't need to be covered? Is it that we're paying people too much? The answer to all that is no. The real core of the problem with Medicaid, turns out it's not really Medicaid's fault. Medicaid operates in the U.S. healthcare system, and the U.S. healthcare system is
90 seconds,
bloated, inefficient, and drives poor quality care. I think that's a blanket indictment, but I think it's fairly accurate. What do we spend in this country on healthcare? We spend 17% of our nation's GDP on healthcare in this country broadly. It may sound like a lot, I don't know, but compare us to the rest of the world. The next highest country is Switzerland at 11. We spend 50% more on healthcare as a proportion of our economy than the next highest. And what do we get? You can argue we have the best healthcare system in the world, but what do we really have? We've got 50 million people who are uninsured, and we have healthcare outcomes, quality measures as defined by anybody you want to talk to, IOM, World Health Organization, what have you. We don't compare with Switzerland when it comes to outcomes. We're comparing to El Salvador, and that ought to be an...
Well, we're going to have to close out here. Did you get that? We compare to El Salvador with outcomes. Well, this is our last show for 2012. We'll be back on January 8th for our next show. We hope that you'll join us then. Until then, we appreciate all you've stuck with us here, and we will see you on January 8th, and we'll talk Medicaid again. Thanks. Look forward to hearing from you.
10 seconds.